Thank you very much, Anna. And it's a pleasure to welcome our first speaker, Professor Ellen Blaak from the University of Maastricht in the Netherlands, who will give a presentation on the story in personalized nutrition, a research update. Please, Ellen.
Okay, thank you, Anne. What I will do is to present some snapshot on research on personalized nutrition. These are my disclosures. So the personalized nutrition project. So why do we each respond so differently to food? And that has, of course, many aspects in it. We can have a differential metabolic response to foods, but we also can have a differential preference to foods. And all those, both the metabolic response as well as preferences are determined by many, many factors. And this shows a little bit the complexity. When we look at the relationship between food and health, they are intertwined and cannot be isolated from their context. So our response to diet depends on our genetic profile, for instance, our microbial profile. It depends on sleep, stress, exercise, and a lot of factors around that. And if we really would like to predict how we respond to food, based on all these factors, indeed we need big data. We need more complex data analysis using mathematical or metabolic modeling to really get insight in that. And I mentioned you several examples from literature who recently did that. This is a well-known study of an Israeli group of SEVI. They predicted the glycemic responses, and they did that in 800 people, and they characterized those people in detail in daily life by means of characterizing microbiome, by doing blood tests, questionnaires, anthropometrics, and by detailing their food intake. And based on all these factors, they developed an algorithm that could predict blood glucose responses in daily life. And they subsequently tested that, and indeed that appeared to work. Of course, these algorithms have to be, I think, validated also in other studies in different contexts to see if it really works under all conditions. And another example is recently published in Cell Metabolism. That's a study on feces transplantation performed at the AMC. The PI of that is Max Newdorp, and we collaborated in this project. What did they do? They transplanted the feces of lean donors to subjects with a metabolic syndrome, and they studied those subjects 6 weeks after the fecal transplantation. And as you see here, the results depicted, indeed, in the subjects with a metabolic syndrome, there was a slight increase in insulin sensitivity after feces transplantation. It was around 10%, so not huge. But what was interesting is that they could predict the responders and non-responders to fecal transplantation by means of the baseline microbial composition. So individuals with a low microbial diversity responded better to fecal transplantations as compared to individuals with a high microbial diversity. So these are two examples that we really can predict the response to intervention towards a more personalized response. But perhaps when we're looking at treatment of obesity and related complications, we may have to focus a little bit more on subgroups, on metabolic subgroups, because of course our metabolic response is much more close to how we actually respond to diet than just using a general prediction model. And I'll mention you several examples from our research where we really looked at the metabolic response to foods. And this is a concept that's often used in literature, that the dynamics of response, so the ability to adapt, is a determining factor for metabolic health in response to diet and environment, also called the metabolic flexibility. And what you see here is the response in carbohydrate and fat oxidation of the body after ingestion of a high-fat mixed meal. And you see that there are certain individuals who respond very well and have an increase in carbohydrate oxidation as a result of ingestion of that meal. They are very flexible, And there are subjects who do not respond that much, do not increase their carbohydrate oxidation very much, and do not decrease their fat oxidation, and they're relatively inflexible. And this metabolic inflexibility has been linked to development of insulin resistance, and of course, whether it's cause or consequence, that's still to be investigated, but had also suggested to play a role in body weight control. And I'll show you some data on that, both after acute and more chronic dietary intervention. Because I already indicated metabolic inflexibility may be related to insulin resistance, but with respect to different metabolic subphenotypes, insulin resistance can develop in different tissues and not perhaps at the same time point, but it may manifest within the liver, skeletal muscle, and adipocyte, and in some subjects it may manifest at the same time. But there also are individuals with more pronounced liver insulin resistance, with more pronounced muscle insulin resistance, and that can indeed be determined how we respond to dietary intake, because of course insulin and insulin resistance plays a very important role in the substrate partitioning within the body, so the nutrient partitioning. So the severity of insulin resistance may differ across tissues. Metabolic consequences may depend on the type of tissue affected. And as I already indicated, the response to diet may vary according to the insulin resistant phenotype. And we study that into more detail also into different pre-diabetic states. When you look at the development of diabetes, we go from a state of normal glucose tolerance towards type 2 diabetes, and you have two intermediate states, either a state of impaired glucose tolerance with disturbed postprandial glucose concentrations, or a state of impaired fasting glucose where your fasting glucose concentration is disturbed. And when we look at the characteristics of those pre-diabetic phenotypes, then we see in subjects with an impaired fasting glucose, they have a near normal peripheral insulin sensitivity, they have a progressive increase in hepatic glucose production, and they have an impaired insulin secretion. So the state of impaired fasting glucose is merely characterized by hepatic insulin resistance. Whereas when we look at the state of impaired glucose tolerance, they have in particular a reduced peripheral insulin sensitivity, a near normal hepatic insulin sensitivity, and more a secondary impairment in insulin secretion. So they're really different phenotypes. And what did we do? We studied skeletal muscle metabolism in those phenotypes and studied to what extent they responded to the dietary fat intake. And of course, a little bit on the development of insulin resistance. We know that when we have an inability to store fat in our adipose tissue, we're going to store that either in liver or muscle, and that's what you see here, a cross-sectional area of muscle with a lot of lipids. And we know when we accumulate lipids in the skeletal muscle, that may be strongly linked to insulin resistance. So tissue-specific increase or decrease in lipid content may cause corresponding changes in tissue-specific insulin action. And this is very schematic from skeletal muscle, when you have indeed an accumulation of lipids, of triacylglycerol, and also the related bioactive lipid metabolites, that's diacylglycerol, fatty acyl-CoA, and ceramides. And that can be driven by either an increased supply to skeletal muscle or a reduced capacity to oxidize. These accumulation of lipid metabolites may interfere with insulin signaling and may drive through that mechanisms also insulin resistance. So what did we do? We studied skeletal muscle metabolism in pre-diabetic individuals with either impaired glucose tolerance or impaired fasting glucose. We did see that in particular in subjects with impaired glucose tolerance, so a more pronounced peripheral insulin resistance, that skeletal muscle lipid handling was disturbed. They had a decreased conversion from free fatty acids to diacylglycerol, so reduced turnover, a reduced ability to oxidize, and through that they may have an increased accumulation of fatty acyl-CoA and ceramides, which may interfere with insulin signaling. And we only found that in the impaired glucose tolerant individuals and not in subjects with impaired fasting glucose. And we subsequently investigated to what extent that was mediated by dietary fat quality, because we studied them in the first instance after a high-fat mixed meal with a high content of saturated fatty acids, and we subsequently studied them after meals with other types of fatty acids, PUFAs, polyunsaturated fatty acids, and MUFAs. And remarkably, we did see that only after saturated fatty acid intake, lipid turnover was disturbed in those individuals, but not after PUFA or MUFA intake. So this clearly illustrates that the insulin-resistant muscle may be characterized by a reduced lipid turnover of, in particular, saturated fatty acids. And then the question arises, is this of relevance for longer-term intervention effects? And I only have a few slides now. I'm looking at the chairs, but almost finished. Indeed, there are some indications that the differential response to dietary fat quality may translate into longer-term intervention effects. And here you see data from the CardioPress study, which is a large lifestyle intervention study in subjects predisposed towards cardiovascular disease. And they studied two diets, either a Mediterranean diet or a low-fat, high-complex carbohydrate diet. And what was the main outcome of this study? That when they divided the subjects at baseline based on their insulin-resistant phenotype, either no insulin-resistant muscle, liver insulin-resistant, or both, that was a strong determinant of intervention outcome. Namely, subjects with liver insulin resistant responded much better to a low-fat, high-carbohydrate diet with a higher increase in disposition index, and that's an indicator of glucose metabolism, a composite measure of insulin secretion and insulin sensitivity, whereas subjects with at baseline a more pronounced muscle insulin resistance responded much better to the Mediterranean diet. So the response to dietary intervention may depend on initial insulin-resistant phenotype and diet composition. So is this a way towards personalized approaches? I really think we have to investigate that first in a prospective manner, but also some post hoc analysis in the European project LibGene, where we also had 4 different diets varying in dietary fat content and quality, also showed that initial level of insulin resistance, as defined by HOMA in this respect, may determine the response to a diet. So people with a high HOMA ER responded best to a diet with a high content of MUFA, Mediterranean diet, or a low-fat, high-carbohydrate diet with added omega-3 fatty acids. So again, an illustration that the initial insulin-resistant phenotype may determine the outcome. So in summary, response to dietary intervention may depend on initial insulin-resistant phenotype and diet composition, and this is just one example of a subgroup-based dietary approach. By targeting insulin resistance, glucose metabolism-related phenotypes, we may optimize the beneficial effect of dietary intervention on cardiometabolic health. But of course, we have to take into account that this always has to be within the context of a healthy diet and lifestyle according to general recommendations. Thank you for your attention, and I hope not to be too much over time.
It was a very, very nice and clear presentation. I could feel that you were trying to speed up, so thank you very much. We don't have time for questions in between. We take the questions and discussion at the end of the session. So now I will let my co-chair introduce the next speaker.
Yes, please write down your questions. We will have 15 minutes at the end if we keep on schedule. So please write it down. So I will introduce Elisabeth Govers. She's the chair of the Dutch Knowledge Center for Dietitians on Obesity. So Ellen is going to talk, is there a practice-based future for personalized nutrition? Thank you, Ellen.
Thank you, Anna. Good morning, everybody. Thank you for coming, and thank you, the organizers, for inviting me. These are my disclosures, none. So let's start with some definitions here. I have to work this microphone a little bit to my... Anyway, the word dietetics has been in use since 2 centuries, as you can see, and the word dietitian was also already in use for 1.5 centuries. And then I want to put your attention to the definition of diet, because here we have a controversy built in already, and I'll get back to that later in my presentation. So you can see a diet is something general and something specific. Now this is a challenge, of course, and IFAD has made a definition of a European dietitian, and we do that with 28 countries and in agreement, in total agreement with everyone involved. So we are autonomous healthcare professionals who assess specific nutritional requirements for populations and individuals. And we translate that in a practical advice that can be used every day. So, and dietetics is the assessment of specific nutritional requirements of populations or individuals. And as you can see on the bottom of this slide, we were not the inventors. Hippocrates was already very much into nutrition, as you all know. So the role of the dietitian in obesity, we have put that in a position paper 8 years ago. And we think dietitians are uniquely qualified to translate the scientific evidence on energy intake and expenditure for individuals and groups. But here comes the quintessence of the story. Dietitians always make a personal assessment of the patient, which does not involve nutrition alone, or weight, or some other criteria like glucose or blood pressure. We take the whole patient into account, so the whole situation of the patient, social, emotional, work-wise, anything, environment, everything that involves the life of the patient and that can influence their food intake, that is taken into account, and that leads to a dietary diagnosis. So that's a much broader picture than just a carbohydrate intake or an energy intake or fiber shortage or whatever. So in short, a dietary advice by a dietitian is always personal and is therefore always personalized nutrition in itself, by definition. So it's always practice-based and it's adjusted to the patient's needs and possibilities. And these can change during a treatment, because a treatment by a dietitian is most of the times long-lasting, especially in obesity care and its comorbidities. We have long-lasting relations with the patients. And I also want to point out the last line on this slide. This is the reason why we as primary care and clinical dietitians are never satisfied with handing out general guidelines to patients, as is suggested many times in obesity care. Not two patients are alike in their needs and possibilities and in the phase of their life that they want to make changes. So it's always personalized nutrition, what we do. So here is a summing up of diets that we definitely don't use lists. We have lists of products, but there's always an individual advice attached to it. So then there's also a program in Europe that was looking into personalized nutrition, but that was something different. It's Food for Me, and they made people fill in questionnaires, and there were 9,000 people doing that in 9 countries, and then they took 1,200 of them and divided them in 4 groups, and they made them fill out questionnaires. They made them report their blood pressure and their cholesterol. That is the group diet and phenotype. And then they made them also make a swab of their saliva and sent that in so the genes could be analyzed. So, and all these groups performed better than the control group, but there were no significant differences. And then Stuart Knox did a review on this, and she found out that the people that were most apt to follow the advices that were given by the internet were the people that were confident that their data were not unsafe, that the data were guarded safely. You know, this is a very actual discussion right now. So that was one of the criteria why people would not follow the advices. They were worried about their personal data. So, but this is not personalized nutrition. It's called personalized nutrition, but personalized nutrition is that I can see the patient face to face and that I can take in his emotions, his or her emotions and their barriers and everything that is added to nutrition, because nutrition is not only about carbohydrates and energy, it's also about emotion. So, and also in my country, you are not allowed to give advice through the internet if you have never seen a patient. That's forbidden by law. So I think that would be in most countries. Now we have to go to obesity, and this is the new definition of obesity. This is not just a fat accumulation as it was. We have 3 groups of morbidities attached to obesity. And if you look at it, the left group is insulin resistant and the right group is most of the time not. But there, of course, there is a combination. You could have like hypertension and coxarthrosis, or you could have cardiovascular disease and sleep apnea, so that you would have both. And when you look at personalized nutrition and you look at patients, this is a cohort I set out in the Netherlands 10 years ago. There were 1,546 adults involved, and we followed them for 6 months, and we saw that, you know, a large percentage were reaching more than 5% weight loss, 40%, then 37% lost 1 to 5%, and then there was also 20% that didn't lose weight at all. So you have to look at the patient. You can't just say we do a hypocaloric diet or we use a diet based on the Dutch dietary guidelines, which are healthy enough, but maybe not beneficial for some patients, as the former speaker also suggested. And we saw that people on a low-carb, high-protein diet, which is not like low-carb, like 20 grams per day, but it's more, but it's less than 100 grams per day, we're losing more weight and losing more waist circumference. So here's food for thought, so to speak. Not everyone is the same, and we need to look at patients very carefully. This is the mapping exercise we did in this program, where we were making the position paper, and you see that most of the dietitians work with the individual assessment, and you see a sort of a choice of diets they give patients. And the ultimate goal in weight management is not working to guidelines. It may improve the quality of obesity care, of course, in general, but it never guarantees successful weight loss on an individual level. Never. A patient is not a guideline. A patient is an individual. And the ultimate goal should be loss of body fat, preferably the abdominal and visceral fat, loss of waist circumference, and reduction of comorbidities. And to reach this, we need personal diets. And these are my conclusions. I have 7 seconds left, so. So, yes, personalized nutrition is essential. Every patient is an individual that needs and deserves individual care. And we need time. RCTs take 6 months. We need a year and a half. Which is good, because if a patient works on his health, he is improving already, and he may not reach the targets we want him to reach, but he will get healthier in the run. So And patients with sick fat disease need other diets than patients with fat mass disease. And not every diet fits every patient, and patients know themselves. Ask your patients, what was successful for you? Because this is a lifelong condition, and you know that people will have that the rest of their life, so they will have tried many things already. So, and we need flexibility, and well, this is what I already said in the previous slide. We need also improvement of quality of life. Thank you for your attention.
Thank you very much. And then I would like to introduce the next speaker, Teodora Handjeva-Galenska from the University of Sofia in Bulgaria, and a dear colleague in the preview project. And Teodora will speak about weight loss as part of a healthy lifestyle. Please, Teodora.
Thank you very much. Good morning, everybody. It's my pleasure to be here. And thank you for the organizers for inviting me. So these are my disclosures. You are very much aware of this balance on energy intake and energy expenditure, and when this balance is disrupted, this could lead to either a weight gain or weight loss. It was established during the last decades that a modest weight loss of 5 to 10% could lead to beneficial effect on health. So weight loss generates a variety of physiological changes that could help prevent diabetes, improve blood pressure, reduce risk of premature death, and reduce risk of heart disease. However, virtually all obese subjects begin weight loss therapy with unrealistically high expectations for weight loss. And an example is by Foster that found that obese persons expect at least 25 to 32% of weight loss of their body, which is not realistic, and it's achievable by metabolic surgery. This weight loss, this mismatch between expected and realistic weight loss could lead to disrupted physiological functions, and this could lead to increased attrition rates. Sustained weight loss, however, does produce a number of important physiological changes, such as increased satisfactory physical appearance, less depressive syndromes, and a high quality of life. A very important and well-known approach to promote weight loss is differential effects of the macronutrients in context of energy content, where fats lead to 9 kilocalories per gram, protein 4 kilocalories per gram, and carbohydrate 4 kilocalories per gram. If we cut the content of fats, this could lead to substantial decrease of energy content, because fat contains more than twice of the energy content of either protein or carbohydrate. Another rational option for weight loss reduction is also related to the differentiation effects of macronutrients and other factors of foods which affect the hunger and satiety. And many studies suggest that protein has a subjectively high satiety effect than compared to carbohydrate, creating an hierarchy of macronutrient satiety. Many healthcare professionals historically recommend low-fat diets for a safe and effective weight loss strategy. Over the last decades, a large amount of research has been generated towards an alternative approaches, such as the low-carb diet, low-GI diet, and some others. And a recent study by Gardner, published in JAMA this year, early this year, showed that low-fat diets are as effective as low-carb diets in the context of weight loss. A meta-analysis of 9 randomized clinical trials related to weight loss and intake of dairy products found that a high intake of dairy products, 1,000 milligrams per day, generates higher weight loss in comparison to low intake of dairy products. And it is well known that dairy products such as yogurt and cheese contain different ingredients that could affect satiety and hunger. This is a picture of my daughter when she was 3, eating yogurt. And as I'm coming from Bulgaria, a country from the Balkans where we eat a lot of yogurt, I'd like to share with you some facts related to this dairy product. In the end of 19th century, the Nobel Prize winner Ilya Mechnikov, a well-known Russian physician and microbiologist, suggested that in the Balkans, people live longer than in the other parts of Europe due to the high consumption of yogurt. And later on, in 1995, his fellow Stamen Grigorov, a well-known Bulgarian physician, found this Lactobacillus bulgaricus, which is the main strain in the nowadays yogurt. Of course, in the last decades, many studies were generated on the effects of dairy products in the management and also in the prevention of cardiometabolic diseases. And when I made this presentation, I found this interesting paper by Dranovsky, published this year, that the production of dairy products generate less CO2 compared to other animal products, such as meat, for instance. So a diet rich on dairy is a sustainable diet. And there's some myths and facts concerning the weight loss. And I'll show you 3 myths and facts which were also presented in a paper published in New England Journal of Medicine. So the first myth is that large rapid weight loss is associated with poorer long-term weight loss outcomes as compared with low gradual weight loss. And the Diogenes trials, which Bulgaria was part, show that if a patient here in blue lose more than 12 kilograms, this is during the weight loss phase, and this group also exert a decrease in weight during the weight maintenance phase. Another myth is that it is important to assess the stage of change or diet readiness in order to have patients who request weight loss treatment. And the fact is that readiness does not predict the magnitude of weight loss or treatment adherence among persons. And the third interesting myth is that sexual activity burns around 300 kilocalories for each participant. I was sure that you will laugh on this slide. And the fact is that given that the average bout of sexual activity lasts around 6 minutes, a man in his early to mid-30s expends approximately 21 calories. And back to the science and to the research. I made my PhD in Copenhagen, and Anne Rabben was one of my opponents during the defense. And we found that in Diogenes studies, there are some predictors of weight loss, such as the initial body weight, early weight loss at the first week, and weight loss at the 3rd week. So all these predictors could predict the final weight loss outcomes at the end of a weight loss therapy. And further, a cutoff point of 2.6 kilogram weight loss at the 1st week is a good predictor for the weight loss outcomes at the end. However, many people fail to lose weight, And this is due, because many studies suggest that this is due to increased sensitivity towards sweet and salt, further reduced metabolic rate, and a lot of changes in the catecholamines concentrations in our body and the thyroid function, as well as an increase of the ghrelin, a hormone that promotes hunger, and a decrease in leptin, a hormone that decreases hunger. And to summarize, modest weight loss has long-term beneficial effects on health and cardiometabolic disorders. Rapid weight loss is associated with positive weight loss outcomes. Predictors of weight loss could be initial weight, body weight, weight loss at the first week and the third week of weight loss therapy, and a weight loss of at least 2.6 kilograms at the first week of weight loss therapy is a practical predictor of a weight loss outcome. And with this, I want to thank for your attention, and I'd like to share that Bulgaria is chairing the presidency of the Council of the European Union this year, and in this regard we organized one-day conference in February which was related to nutrition in children. Thank you very much.
Thank you, Theodora, and without any delays, I welcome Snezana Polovina. Snezana, she's a doctor at Clinical Center of Serbia, and she's also working in the Faculty of Pharmacy in Novi Sad. Thank you.
Thank you, dear Anas, and dear colleagues. I will try to give you an answer whether substantial weight loss could be helpful in obesity-related conditions. So, as you know, the variety of obesity initial conditions are very wide, and everything is beginning with dysfunctional fat cells. And various comorbidities following obesity require practice guidelines for treatment. So, as you know, the therapy for diabetes concerning BMI is very different. For BMI between 25 and 26.9, we should recommend it just behavioral therapy and diet and physical activity. And for those patients which have BMI over the 40, we should recommend it medications and also bariatric surgery. So, but what is the difference between obese diabetics and non-obese diabetics? In obese diabetics, we should add on metformin after the lifestyle change, and if it's failed, we should add on one more oral anti-diabetic. In non-obese, we should add on one more anti-diabetic. But in obese diabetics, we, in the case of failed of combination of metformin and one more anti-diabetes, we should shift the therapy from oral anti-diabetics to anti-obesity drugs. And this is a big difference. So the weight loss, about 10% in obese diabetics, improve glycemic control, but not just glycemic control, also improve or reduce cardiovascular risk. It is due to improved insulin sensitivity, changing gastrointestinal hormone secretion, and so on. So with bariatric surgery, we should resolve type 2 diabetes in 73%. And our patient with metabolic syndrome could be resolved in 90% after substantial weight loss after bariatric surgery. Mechanisms for obesity-induced hypertension are well known. But what are the recommendations for therapy? For stage 1 hypertension in obese people, we should not give them antihypertensive drugs. We should advise them changing lifestyle, weight loss, then we should give them anti-obesity drugs. Eventually, if they fail this treatment, we should recommend bariatric surgery. But in stage 2, we should give them antihypertensive drugs. That is big differences between normal weight people and obese people with hypertension. And after the surgery, after the huge weight loss, more than 15%, weight reduction with anti-obesity drugs reduced number of antihypertensive drugs between 30% and 84%. So it's really helpful. And this is our experience after gastric bypass and weight loss between 35 and 40%. Systolic and diastolic blood pressure in rest drop down, and also maximal systolic and diastolic blood pressure reduced. So after bariatric surgery, hypertension could be resolved in 63%. Increased cardiovascular risk in obesity requires to establish a strategy for early prevention of obesity-induced cardiovascular disease. And the first on this list is dyslipidemia. Dyslipidemia could be improved with medical as well with surgery treatment of obesity about 65%. So weight loss in dyslipidemia is really helpful. You know that obesity is disruptor of the female fertility, and the underlying mechanism is probably insulin resistance. And treatment of obesity with lifestyle intervention or with or without anti-obesity drugs and metformin could be really helpful, because that carries benefit of weight reduction, including improvement of pregnancy rates. So the reduction of weight just of 5% significantly improve level of free testosterone, LH, and insulin levels with improvement of ovulation rate. So polycystic ovary syndrome could be resolved in incredible 96% after bariatric surgery. Male obesity secondary hypogonadism, which is common state in extreme obesity males, could be treated with weight reduction. And this study has shown that lifestyle change improved body composition and hormonal profile, represented by total testosterone, which increased after 6 months, and 17-beta estradiol decrease after 70 months with weight reduction of 10%. One more condition related with obesity is obstructive sleep apnea in adults, and the first treatment we should recommend it for those patients is weight reduction. After bariatric surgery, obstructive sleep apnea could resolve between 45 and 78%. And we have one more condition. It's non-alcoholic fatty liver disease, which it is definitely could be managed by weight loss. And it is very interesting that after bariatric surgery, fibrosis in non-alcoholic fatty liver disease could be result in 12% fibrosis. And inflammation could be result in 37%, and fat deposition in the hepatocyte could be result almost in 100%. So, what we can conclude? We can conclude that different stages of obesity-related comorbidities require different treatment. But weight reduction is the first step, and it is the main therapeutic approach in management of obesity-related conditions in all stages of obesity-related conditions. Thank you.
Thank you very much, and thank you also for keeping the time so elegantly. Very good. We will move on to our next speaker, Solveig Sigurdardottir from Iceland, who will talk about eat your way to a healthier diet from her own experiences in life. So please, Solveig.
Thank you. Good morning to you all. I don't believe I'm standing here today. I do come from the Patient Council of EASO, and we don't have a loud voice in a conference like this, so I would like to thank you so much for having me today. Thank you. So let's start. If you want to know more about the Patient Council and the stories about the patient in the EASO, you go to the website and you find the Patient Council, and you can click and find my story among many others from all around Europe. Thank you. So, eat your way to better health. Sounds really nice, but is it possible? Changing my views on how to live healthy is probably one of the most important things I have done in my life. It was a big step forward, but it didn't happen overnight. After trying practically everything the industry had to offer on dieting and weight loss, I sat down to rethink I couldn't go on carrying this burden of weight around. It was hard enough just getting through the day, excruciating pain every day, and the endless negative thoughts about myself was getting unbearable. I was my worst enemy. My life was getting very difficult, and my MS was progressing very fast. It was very exhausted, physically and mentally. It all started with my one-year program in Helsingborg in Reykjavik, Iceland. I became fascinated by the way of dealing with obesity. By changing my lifestyle, the diet improved, and I began to be interested in healthy food and healthy living. Today I work with a team of specialists to help others change their lifestyle. I have attended numerous cooking classes both in Iceland and in the UK. All of them emphasize healthier cooking. Today I have my own demonstration as well as tasting of healthy and nutritious food at Helsingborg. Those courses are in collaboration with Erla Gerður, doctor at Helsingborg. First, she educates about healthy lifestyle and diet, and then I take over with my cooking and information about food. I teach cooking and how to prepare healthy meals, as well as assisting with grocery shopping. I find that so important. Today, there are thousands of people who have attended those courses. It's becoming more popular every year. We also work in collaboration with Sidekick Health. That's an app where my recipes and other information are on the app. I have a Facebook page with about 11,000 followers, which is quite good considering that the population of Iceland is only 360,000 in total. I also have held lectures and cooking courses in various places in Iceland. So that's Helsingborg, that's our new center and located in Reykjavik. The 12-month multidisciplinary program where professionals and former patients work with patients, both individually and groups, to get the best result. Education, training, and online support is included. I found that really, really important. The program is also adjusted for those individuals who plan to have a bariatric surgery and support them after surgery as well. That is very important. The family physician, Erla Gerður Sveinsdóttir, is one of the Heilsuborg's founders. For more than a decade, she has been assisting people fighting obesity. She was the president of the Icelandic Association for the Study of Obesity for 6 years. Heilsuborg offers various clinical care, diagnosis, treatment, and psychological support along with the lifestyle change program. Heilsuborg multifunctional approach is based on assisting people to make change in their daily life towards a better health. Respecting individuals' needs, small changes are made at first, allowing the body and mind to get used to the new way of life. There are 4 main areas that needed attention. This I never knew before. I just thought of like losing weight. That's nutrition, exercise, sleep, and peace of mind. Combining those things in daily life is a challenge. It includes giving the body the nourishment it requires and nourishing the soul at the same time. The key is to choose an individual approach that each particular can sustain lifelong. This method is more likely to result in a long-lasting weight loss, as people have changed their daily habits to fit their own way of life. Good nutrition is an essential part of a healthy lifestyle. That's the fact. Effort goes into getting people on a good track regarding nutrition, using healthy, unexposed food, diverse and appealing foods, to relearn how to eat healthy food and feel good about it. Not to starve yourself, but to eat better food and enjoy it. In this diet, nothing is forbidden. Gradually, people start to choose food that supports their health. Little by little, it will become easier and more natural. Strengthening the body with exercise, improving sleeping habits, and working towards a balanced mind will make that disease a diverse piece in the puzzle of come together. No one can change your lifestyle except you. However, you can find support, encouragement, education, and ideas from others. Step by step, you will reach your goals towards improved health and better quality of life. And that's all I think it is better quality of life. And for me, that was the most important thing when I sort of found my way into a new lifestyle 6 years ago, was to take the pressure out of putting people on a strict diet. Thank you.
Thank you so much. I think we are ready now to welcome Maria Hassapidou for our second part. We are very well behaved, so we are on track with our time. Not only Maria, she's leading this nutrition working group. Maria, she is a professor at the Department of Nutrition and Dietetics of the Alexander Technological Educational Institute of Thessaloniki in Greece.
Thank you, Anna. Good morning. Now this, let's call it the second part of this workshop. I will try quickly to present our position paper with the title Dietary Management of Obesity in Adults, Pitfalls and Opportunities in Europe. I would like to say that this was a collaborative work between all the members of the Nutrition Working Group, and I want to thank you all. And this report, this position paper, has not been published yet. It has been submitted to the Obesity Facts and will be published soon. And when it will be published, you will be able to find it in the website of EASO. So today I'm just going to present the basic points. So what have we done in this report? In this report, we present First of all, in the first section, a review of the existing national guidelines for the dietary treatment of obesity in Europe, as well as the results of a survey we did in the European countries. And this survey describes the role and the current practices in the dietary treatment of obesity. We also gathered some evidence, the latest evidence, on obesity management and interventions around Europe for obesity prevention. And all this, it was analyzed in order to identify a common ground and existing gaps in the knowledge and practice of dietary treatment of obesity. So in our first section, as I said, is the current status in the dietary management of obesity in Europe. And this exercise actually started in 2014 from the European Specialized Dietetic Network of Obesity, ESDN Obesity as we call it, of IFAD. You heard about IFAD before, the European Federation of the Association of Dietitians. And we mapped guidelines on obesity in Europe with the following two aims. First of all, to compare the guidelines for obesity management across Europe, and second, to stimulate dietitians to work according to guidelines for improving quality and evidence-based care. Later on, in 2016, we also had an online questionnaire that was sent in all 34 IFAD association members, requesting them to forward this questionnaire to their national obesity special dietitians in order, as I said, to map, if possible, the current practice of the dietary treatment of obesity in Europe. We had 229 questionnaires that were returned, and out of them we had 185 valid questionnaires from 22 European countries. So we did gather a lot of information for what is happening around Europe. And there are many results, but I'll try to really show you probably the most characteristic ones. First of all, what we found out that there are different goals in the national guidelines. So there are differences in the different countries regarding the goals. So for example, you can see in the Netherlands, the goal is a reduction of body weight of 5 to 15%, but you can see, for example, that in Italy is 10% weight loss in the recommendation. But for example, in Germany, there are two categories. If your BMI is between 25 to 35, then the goal is 5% weight loss, or whereas the BMI is more than 35, the goal is 10% weight loss. So differences between countries, and differences between what we call weight loss maintenance. Some pay more attention than others, and some are talking about, for example, in Great Britain, for a 5-year weight maintenance program, or some others, like in the Netherlands, they talk about 2-year weight loss program, but some other countries don't mention that at all in guidelines from other countries. So we figure out that there were a lot of differences regarding the treatment goals. And also we would try to figure out what are the tools that they are using for the obesity diagnosis. So what we found out is that 90% are using height, weight, and BMI as a diagnostic tool. And only 64% measure, they're doing the measurement of waist circumference regularly, and 64% only measure body composition. And as Ellen saw the same slide before, we also gathered information regarding the type of dietary interventions, and we found a lot of differences. For example, it's interesting that 65% answered that they are based the dietary intervention on individual dietary assessment, but we found differences around European countries regarding recommendations on different type of diets, like Mediterranean diet, low-fat diet, low-carbohydrate or high-protein diet, or very low-caloric diet. In our second part, we try to gather the obesity prevention strategies in Europe. And we gathered a number of different strategies. And I'm not going to go through all of them, you can see them in the slides, but I want to stress that there were different strategies in different countries. For example, in Germany and Italy and UK and Sweden, they encourage the moderate consumption in alcohol, or they ensure adequate intake in nutrients in Sweden, Norway, Denmark. You can see the countries, and you can see the obesity prevention strategies. Most of them are very interesting strategies, but there are a lot of difference between what is suggested in each country. And this is what made us understand that we need to have European guidelines that will try to really, as we gather all this information, analyze them, and end up with, finding out what we think is evidence-based. So after we concluded this position paper, we will follow with this, what we call European guidelines, evidence-based European guidelines for obesity. And the first part, as I said, is for adults, and we're hoping next year to also do the same mapping exercise for children and go on with producing or developing European guidelines for children. And you can see some more of the prevention strategies that we gather. For example, drinking water instead of sugary drinks was only recommended as a prevention for obesity in UK and the Netherlands. And limit the portion sizes, which I'm sure you all believe it's very important. It was only mentioned in the UK strategies. For example, reducing intake of saturated fat was recommended in more countries, but in not all the 22 countries. And what we did with the section 3 of our position paper, we tried to see what is in the literature. We did a review, and what of this dietary treatment for obesity management are, I would say, evidence-based. So we try to have the evidence-based methods presented in this section. And I will go through the 10 important evidence-based recommendations for the dietary treatment. And the first one is the reduction in body weight. That it's a strong evidence that we need to suggest a 5 to 15 weight loss over a period of 6 months. This is realistic, and it has been proven of health benefit. Prescribe a diet to achieve reduced calorie intake for obese or overweight individual who would benefit from weight loss as part of a comprehensive lifestyle intervention, as all the previous speaker also stressed. And this, you can do it in 2 ways. You either prescribe a diet from 1,200 to 1,500 kilocalories per day for women and 1,500 to 1,800 kilocalories per day for men, or you prescribe a 500 kilocalorie per day or 750 to 1,000 kilocalorie energy deficit. You prescribe a calorie-restricted diet for obese or overweight individual who would benefit from weight loss based on the patient preferences and based on the patient health status. I'm going to use again the term personalized nutrition. And preferably, this could be done by a nutrition professional, a registered dietitian for counseling. We do know that significant clinical benefits, against mentioned from the previous speakers, may be achieved even by modest weight loss. Again, we mentioned the 5 to 10% loss of initial body weight. Together with lifestyle modification, through improved nutritional content of the diet and modest increase in physical activity and fitness. That should be part for any program. Lifestyle changes that produce even modest sustained weight loss of 3 to 5%, a lower weight loss, produce sometimes clinically meaningful health benefits, and greater weight loss produce greater benefits. Sustained weight loss of 3 to 5% is likely to result in clinically meaningful reductions, and you heard it again from the previous speakers, in triglycerides, blood glucose, hemoglobin, A1C, and the risk of developing type 2 diabetes. And greater amounts of weight loss can reduce blood pressure, they can improve LDL cholesterol and HDL cholesterol, and reduce the need for medication to control blood pressure, blood glucose, and lipids, as well as further reduce triglycerides and blood glucose. More attention should be paid to measuring waist circumference and improving body composition, focused on ameliorating or maintaining the free fat mass and decreasing fat mass. Balanced hypocaloric diets can be tailored to individual patients on the basis of personal and cultural preferences and may therefore have the best chance for long-term success. And we do have a lot of evidence-based paper for the Mediterranean diet. Advise overweight and obese individuals who would benefit from the weight loss to participate in more than 6 months in a comprehensive lifestyle program that assist participants in adhering to a lower caloric diet to increase physical activity through the use of behavioral strategies. Advise overweight and obese individuals who have lost weight to participate in a long-term, more than 1 year, in a comprehensive weight loss maintenance program. And as I'm sure you all know, the weight loss maintenance programs are very important, and this is better to be done face-to-face, but if this is not possible, then a telephone-delivered weight loss maintenance program that provides a regular contact, monthly or more frequently, with a trained interventionist, and with a trained interventionist is registered dietitians, psychologists, exercise specialists, health counselors, or professionally training. So this will help participants to engage in high levels of physical activity, 200 to 300 minutes per week, to monitor body weight regularly, weekly or more frequently, and consume a reduced calorie diet, that diet that is needed to maintain the lower body weight that they achieved. Finally, we don't have a strong evidence, but it's a moderate evidence for the use of very low calorie diet, less than 800 kilocalories per day. This should be used only in very limited circumstances, and it should be used only by trained practitioners. Medical supervision is required because of a rapid rate of weight loss and of potential for health complications. In conclusion, this was a very quick overview of what we have written in this report, and I will conclude with some gaps and future steps. Which diet is optimal for health, for weight loss, and for health and maintenance remains controversial and implies that no diet fits all patients. It is evident that more research is required on the factors that determine weight loss and weight maintenance in metabolically distinct subgroups. And we heard of recent data that have shown that dietary habits, anthropometrics, physical activity, and gut microbiota can predict personalized glycemic and metabolic responses. We also know that there are a number of gaps on the role of certain foods and the role they play in the treatment of obesity. Studies illustrate that the response to an intervention depends on a great variety of factors, including diet composition, protein, carbohydrates, fat, dietary fiber, food products, the physiological metabolic phenotype, the microbial profile, as well as lifestyle factors, including sleep, stress, physical activity, and all this should be taken into account. Because it is now clear that patients have different profiles and therefore react differently to interventions. We are hoping and we are looking forward to the advances in system biology, in the omics methodologies, and new methodologies using new technology for quantifying dietary intake in a better way, and lifestyle factors like measuring very properly and correctly with new technologies energy expenditure. And we are hoping that these advances will yield new possibilities for more personalized or subgroup-based dietary strategies. Thank you very much.
Okay, thank you so much. I would like to open now for 15 minutes discussion. And the way we will do it is I will ask Maria to be there and the rest of the speakers just to stay there, no problem. I'll just ask for a microphone in the front if there's possible. Wireless microphone. Okay.
Okay.
And we will give some time for people just to, wait just a second, 1 second. Is there a microphone? Otherwise, I will have to ask for you.
Yeah, it's working, so.
No, I'm not meaning you, I'm meaning my speakers.
All right.
That's the reason.
Actually, what we are going to do, if there is a speaker, we call
Yeah.
to answer,
If
depending
there's no-
on which speaker
Yeah.
you are addressing the question. I think the best way is that we'll call the speaker. So please let us know which speaker you
Okay.
are addressing the
Okay.
question.
Okay, so we will start with you in the front. Please identify yourself and let us know where you come from. Thank you.
Good morning, everybody. My name is Berenice. I'm French, working in the Netherlands and, as a dietitian. I have a question for Solveig from Iceland. Thank you for your intervention. You have given the presentation we were missing here. You know, something concrete. We hear a lot of good presentations, but we are missing the link to a concrete program. So I was really interested, how do you use a game, the gaming application working with people with obesity? How do you put it in your program?
How do I put it in my program?
You use a Sidekicks Health app.
Yeah.
So this is very interesting because this is a promising development for us nutritionists.
Yeah, this is quite new at the moment. Sidekick Health
Yeah.
is a program now they started in Helsingborg in Reykjavik. So it's working with a group and they have 1 year program. Actually, you can have 6 months and 1 year. So I come in as a former patient and it is different for a patient to speak to another patient than talk to a doctor, nutritionist, or the people who works there. Because sometimes you have been hurt as an obese person. And most of us, we have been burned from the health system. So I'm quite of like a little bridge between the healthcare system and for the patient when they start.
But how do they use the app? Does everybody has to get into the app?
Yeah, the app is in the 1 year program. Called Heilsuløsnir, the health solution. And that's, I think there's 4 or 5 months in the beginning, and then people can continue on their own with the app.
And do you see, as a practitioner, do you see what they're entering or what they're doing?
In the beginning, I had no idea what was going on, but I like the app. And I think it's more important now to have that kind of thing, because many people, they don't have places to go to. So having app and online study as well is quite good.
Okay, thank you.
Thank you.
Please.
Okay, thank you.
Yeah.
Umberto Cornelli, Loyola University, Chicago Medical School. I have a couple of questions. The first one is for Professor Blaak, and is dealing with the insulin resistance. Now, for the young doctors here, I would say that the physiology of insulin resistant is the following. The sugar, when it gets into a cell, follows 3 ways. One, glycogen synthesis. The second one, energy. The third one, for 3% of the glucose, is a transformation in diphosphoruridine glucosamine and get insulin resistant. So insulin resistance is a physiological process. And one of the major producer of insulin resistance is the gut, where we absorb glucose. I've not seen reporting insulin resistance in relation to the gut in any of these speeches. So we will not end up with a solution. You know, if you give antibiotics to a man, you will see that the blood glucose goes down. Why? Because of insulin resistance.
What's exactly the question then? Can you?
The question is the diet. You know, I appreciate very much the Hassapidou speech. I appreciate very much, but I have a point. I was testing the diet through all Italy, and not only in Italy. And in every region, the diet is different. And in every region, taking the single villages, the diet is different. And in every village, in every family, the diet is different. So my concern is we should set up family guidelines. Yeah, thank you.
Okay, maybe Ellen, you ask.
Yeah. With respect to the first, I fully agree that the insulin resistance indeed is very much determined by a very complex inter-organ crosstalk, including the gut, the adipose tissue, liver, muscle. I fully agree with that. Yeah. If that's the question.
Yeah.
Okay.
And regarding the family recommendations, we had a discussion on Wednesday in the Childhood Obesity Task Force, and my presentation was on the importance of having family recommendation. I totally agree with you.
Okay.
Well, thank you, Tommy Visser from the Netherlands. Before I ask my question, I first like to congratulate Solveig. Solveig is the only non-scientific speaker, but your contribution again was at least as important as many other speeches we have heard this week. So congratulations, Solveig, well done. My question is to Maria, perhaps to the other speakers as well. With my public hat on, I was very happy to see your 10th recommendation that we should avoid or at least limit very low calorie diets. It goes against any guidelines and it goes against any lesson we teach in public health. It does have nothing to do with learning the real underlying drivers of obesity. So that's a very good message. It fits very well in the public health arena. I'm learning here about evidence that the responses are different in different persons, doing different things, different genes, different phenotypes. Is there also evidence, because your reason for your 10th recommendation are there may be risks which we understand. Is there also evidence that the responses to the healthy diets are different if you have been through a very low calorie diet? Because that would be an extra very good reason to limit.
So you mean that if you are in a very low calorie diet,
yes,
and then what is going to be your adaptation and difference after you finish the low calorie diet?
Exactly.
Yes, I see. I don't know, do you want to any one of you has any comments on that? About what happens after you do a very low calorie diet?
Yes. Actually, I fully agree that focus has to be on your first point, on a healthy lifestyle, just eating healthy and physical activity, and not on weight loss per se. But I think, yeah, we all agree on that. Yeah. With respect to the second point, yeah, of course, that's a little bit controversial. There are, on one hand, and that was presented, some indication that it doesn't make any difference if you lose very rapidly weight on a very low calorie diet or another diet for long-term weight maintenance. On the other hand, there also are some indications that indeed with considerable weight loss that you have a kind of metabolic adaptation which promotes again weight regain. So it's
yeah, so that's,
but at least we know that weight regain happens in many subjects. So in that respect, I think focus on a healthy lifestyle should be, or changing lifestyle should be first priority. At least, yeah. Perhaps there are also additions or other views with respect to that. But
yeah, I would say that there is a gap there, and you're definitely right, but we haven't really seen what are the physiological changes.
Yeah, so
we
it
haven't
seems
really,
inspiring to
yes,
me to
you're
further
definitely right,
strengthen
we need more work on
our
that.
collaboration.
Because we keep on saying, the dietitians, that if you follow such a diet, then your metabolism, your basal metabolism is reduced, and then you don't lose weight so quickly. But I don't think we have evidence, real good trials on that. And thank you, this is a very good suggestion for a future project.
Thank you very much for your comments. I would like to add on the LCD aspect that it can actually be very motivational for subjects if they lose quite rapidly, maybe 8–10% of their body weight. It is really motivational, at least what we see in the preview project. They are very keen on sticking below their original diet and changing their lifestyle after such a relatively short period of LCD of 8 weeks or 10 maybe. So it's not completely, well, I would say it has its value in that respect.
Thank you. We'll proceed with
Katja Martins from the Norwegian University of Science and Technology, and I would like to continue the discussion that we have just had on very low energy diets. And I do not understand why the last speaker considered that the evidence is only modest for the use of very low energy diets, but it is strong for the use of low calorie diets. Because in fact we have the golden standard research standing on that. We have the study from Purcell, published in Lancet Endocrinology a couple of years ago, that showed that losing weight fast, 15% of baseline weight with very low energy diet, versus losing the same amount of weight gradually with a low calorie diet, induced exactly the same changes in body composition, and that after 3 years of follow-up, weight regain was exactly the same.
The same, yeah.
And
right.
also, and very importantly, as Professor Raben has also pointed out, the completion rate was significantly higher in the VLED group compared with the LCD group. And I believe that there are 2 reasons for that. First, the participants saw the results very fast, and that can work as a motivational factor. And second, with VLCDs that are ketogenic, opposite LCDs that are not, participants do not feel hungry while they are on the diet. And that can help them progressing with weight loss. So I think that is very important. So when you talk about complications, I cannot think about any complication with the exception, of course, of an increased risk of biliary disorders and cholecystectomy. So I believe VLCDs are one option that can be used as many others, and that can be very good as a kickoff to produce a large weight loss at the beginning.
Well, I will just say that it's a very controversial subject, as it was said before, and it will take us a long time to discuss it. But generally speaking, what I could say, and I will give, of course, the floor to my colleagues to also comment on that, is that when we're talking, first of all, we have to make clear what we're talking about, the very low-calorie diets. We're talking about diets
less than 800
less than 800, and then we are talking about diets that should be prescribed in such a way that will cover all the macro and micronutrients. And you do know, if you're a dietitian, this is very difficult.
I am, thank you.
Yeah.
Could I add something?
Yes,
Sorry?
definitely, sorry.
We just said that a low-calorie diet, very low-calorie diet, should only be administered in very professional setting, and not, as we see now, that you can obtain that in a pharmacy and do it yourself at home in your own way. That's not good. That's uncontrolled.
For sure.
And we are
Dietitian is
against
required
that.
as with any dietary intervention, so I'm not supposing
Yes.
that it can be used
by
everyone without
No, but it has to be a
necessary
controlled environment for a limited period of time, and then it's very beneficial for some patients indeed. So, but it's not now, in some countries you can get this over the counter in a pharmacy, you know? If you want to lose your bikini kilos, so to
I completely
speak.
agree with you. My
And that
question
is
was
counterproductive.
Because the moderate regarded in comparison with strong, that was a way we chose to evaluate the results, is that we do have some studies, exactly as Ellen said, that we cannot actually give these diets unless it's under medical supervision. It's a diet that we cannot, and as very well was stressed before, we cannot use it in public health.
yes, for sure.
Okay, maybe we stick to or go to another subject of the presentations before.
My question
we have
is a
a
different
question
subject.
over there.
Hi, my name is Enzo Di Battista. I'm from the University of South Wales in the UK. I enjoyed all the presentations. I could probably ask each one of you a question based on what you talked about. It was all superb. I'm particularly interested in the first presentation from Ellen Blaak, mostly because it overlinks with some of the work that I'm doing. And you mentioned about the personalised approach based on HOMA, and that some increases in HOMA, they would respond better in things like the Mediterranean diet and potentially a low-fat diet but with omega-3 fatty acid. One of the challenges that I've got, that I'm trying to overcome, and there has been a good review recently, is actually trying to define what low HOMA is. There's so much variation in the literature. That's my first part, so if you can help me with that. And just some of your thoughts on these diet approaches and the reasons why it helps with using HOMA as a diagnostic approach.
Yes, yeah, what I did present is indeed some post hoc analysis in the Lipgene study, and they
yes, that's right.
Overall there was no effect of diet on insulin sensitivity, and then they did some additional analysis, divided the group in high HOMA and low HOMA, and they saw a differential effect of diet. If it's related to HOMA per se, or whether HOMA is related to other measures of insulin resistance, as I indicated also in the first example, I took more tissue-specific insulin resistance. That also may be the case. So I wouldn't advise to take HOMA as criterion, but to do a little bit more detailed phenotyping on where the insulin resistance is really located. If you, because HOMA is of course a measure of whole body insulin resistance, may reflect to some extent a little bit more liver, but
you would argue that, sorry,
really,
very quick comeback,
yes.
You would argue more so then that it is more helpful in terms of liver disease. You mentioned liver as a specific site for insulin resistance. You arguing that it's liver.
Our idea at the moment is that it may make a difference where you have the most pronounced disturbances at which tissue, if it's more liver or muscle or adipose tissue, and based on that dietary intervention may differ at least. But all those things have to be still to be tested in a prospective manner. So merely they're based on post hoc analysis at the moment.
Okay, thank you.
I can do that.
Thank you. Last question.
I have a question for the last speaker. You mentioned one of the points of the position paper, 5 to 15% weight loss over 6 months. How relevant is the 6-month period in the sense, if one aims for 5 to 15% over a 1-year period, would the progress be too slow? Might it have a negative effect on the psyche and we don't see enough results? Is the 6-month very relevant?
Because most of the studies, if I understand your question, and please help me if you want to answer something more than that, what I understood is that in the literature, what we do find evidence-based, most of the studies, they have the intervention for 6 months. And this is why we use that. I mean, it was most of the trials. So that's why we included this 6 months. This is where we have the most evidence-based data.
So it would appear to be the optimal period for this target weight loss, evidence-based.
Do you want to do?
Okay.
It is the evidence we have for 6 months because RCTs run for 6 months. But as I explained in my lecture, we can treat patients for a year, year and a half. And if they reach 15% in a year and a half, that's a tremendous success. Because these patients are far more complicated than the population included in an RCT. Because these people we treat are excluded from RCT groups.
Yeah.
Thank you all very much. Thank you especially to the speakers and to everybody participating.